Hello, good evening, good afternoon, good morning, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a professor in the Medical Education Research and Development Unit in the Faculty of Medicine at the University of Malaya. I'm joined by two fellow senseis, Prof. Sele, who is an obstetrician in the Kingdom of Brunei, and Mr. Chris Caddy, a retired plastic surgeon and ex-counsel of the Royal College of Surgeons of Edinburgh. Welcome to the Black Belt Academy. Thanks to IACO, we're now reaching 30 countries across the globe, and this is really your program to ask you to ask questions. And we had a very good session last week from Dr. Geeta Lau, who was talking about musculoskeletal disorders prevalent within the surgical population, all because we are not taught to stand and we do not practice to stand as well. With that in mind, this evening's session is on the function of the upper limb and the hand and the surgeon, and to highlight some important principles that I believe will help you in your training and future careers. So as part of our theatre briefing this evening, I would like to ask if everybody has adjusted the height of their tables. And if you're not standing, perhaps you would like to stand for a moment and stand and pretend you're standing at a table. And does everybody understand why the correct height is important? So that's an open question to people who are participating. And Kavitha or Wechi, do you understand why the table height is important? Put it in the chat or answer directly, please. Okay, we've got a bit of a shy group this evening. So the next thing I want you to do is, from the table, reduce the risk of back pain and strain, indeed. But also, standing properly is putting your upper limb in a functional position to enable you to do the job. So I want you to pick up your pencil and just examine how you're picking up your pencil, please. So we have one person. I have very bad back pain. If I bend over, I end up using my weak back muscles to support bending over. Yes, not good at the beginning of a career, certainly. So I want you to pick up your pencils and think to yourself, are you holding your pencil or is it holding you? And if you look at the way we use a pencil and write, we are continually using our flexors and extensors of our forearm muscles to move the pencil to sign our name. This movement and rolling the pencil and this movement is very useful for all instruments that are designed, like Castellievos, for finger use. Note that in doing this, I'm using my fingers to write, but I'm not using my wrist, and I'm certainly not using my forearm. And I was reminded of this by a trainee, Syed, who was taking them through bottom ends of coronary artery bypass grafts using Castellievos, which is a finger-held instrument. And I was wondering why, and even in the skills lab, we were having difficulty. Until one day, we're in the office and he needed to sign, as a co-author, his name on a paper. And he started to sign like this. And I suddenly realized what the problem was in teaching Syed to use coronary instruments. There was no finger movement as there's writing at all. There wasn't even a wrist movement, and it was all upper limb movement like this. What was interesting is that I had to teach him how to write again, how to hold the pen, and how to use the flexors and extensions to make a signature. This flex and extension, the fingers, is holding the instrument in the three fingers, middle, index, and thumb. And it's that grip that has enabled us not only to write poetry and prose, but also to advance in painting and fine art. So the next question comes from is, where does rotation occur in the upper limb? So anybody put in the chat will answer, where does rotation occur in the upper limb? Well, as I'm standing here with the Black Belt Academy circle, I can actually take my arm round. It's a nice trick you can do with a chalk on a blackboard is, can you circumscribe a circle with your shoulder? And the answer to that is yes, because the shoulder, and let me bring in my friend here to explain. The shoulder is a very shallow glenohumeral joint, and that enables it quite a lot of rotation, flexion, extension, adduction, abduction. But combined with the movement of the scapula, you've got a full range of movement. But we don't operate with our shoulders. The next is, where does rotation occur in the lower limb? Well, people would actually say, and often in OSATs, they talk about the flick of the wrist. Well, let's have a look at the wrist. Okay, there you go. All it's capable of is flexion, extension, adduction, and abduction. Putting those together, that is not rotation. Far from it. There's no bone here in that joint demonstrating any form of rotation at all. Just look at that more carefully. Flexion, extension, abduction, abduction. So we are not going to see rotation with a flick of a wrist. And that is a total misnomer. And flick of the wrist is what you do to gaff a fish. That is not a controlled rotation. So the rotation of the forearm is pronation, the radius folding over the ulna, like that. And that is only possible because of that joint there. And let's just zoom in a little bit. You will notice that the head of the radius is actually circular. There. And that enables the radius to fold over the ulna. And that is the rotation of the forearm. Now, it's very important that you understand where the movement occurs in the forearm. I'm just having problems getting with focus at the moment. So let's be clear. We don't operate with the shoulder. The wrist is circumduction, flexion, extension, adduction, abduction, but the rotation is there, with the radius folding over the ulna. And there's a muscle on the lateral aspect here that stabilizes the ulna. It's called the anconeus muscle. And the anconeus muscle prevents the ulnar drift that is happening as you pronate and supinate. The other thing to notice, and I'll take this back a little bit, and as I talk, I want you to stand there for a moment. Please put your arms up in the air and hold them up for the moment. Abduct the arms, okay? And as you abduct the arms, note that the movement is limited, okay? The upper arm and placement of the hands is extremely limited. But even for this short period of time, holding the arms up in the air, you are starting to feel tired. And that is because there are 17 muscles inserting and arising from the scapula. And the shoulder girdle sits in a relaxed fashion with the scapula on the chest wall in a neutral position. And as soon as you elevate or move the scapula round the chest wall, you are employing 17 different muscles. And those 17 different muscles are adding to the strain of poor posture. One of the things you'll find that as we operate, surgeons tend to abduct. And if you notice that the way to actually reduce the abduction is step in to your arm to reduce the abduction and bring the scapula back into a normal anatomical position to reduce the strain on your upper leg. So I'll keep that there for a moment. And that is relaxed. So if you can pop your elbows down now. So the thing is that when you understand the function of the shoulder, pronation, supination, flexion, extension of the elbows, at the end of your limb, you have the hand. And the hand is one of evolution's most extraordinary achievements. A structure so sophisticated that there are 5,000 tactile receptors in every square centimetre on your fingertip, allowing you to feel the difference between healthy tissue and disease, although it's through a tip of an instrument. And there's no other creature on earth that actually possesses this skill. And yet in operating theatres around the world, this routine gift is often overridden by poor posture, poor understanding of the functional anatomy of the upper limb, by instruments that grip too tightly, and by forces that crush the very tissues the surgeons are supposed to protect. So this lesson is getting you to understand and use what the human hand is designed for. Firstly, I want you to now pinch your forearm like that. Pinch your forearm like that. And in pinching your forearm, you are generating in males between 35 newtons of force and in women 25 newtons of force. And if we take, for example, the end of a DeBakey forceps as approximately 5 millimeters squared, for convenience, 35 divided by 5 millimeters squared, or 25 divided by 5 millimeters squared. Answers in the chat room, please. At the touch of a button. There you go. Ask this question of 3.1 trainees. We learn maths at school, and they'll come up with 5. But of course, it's 5 millimeters squared, and it's 10 to the 6 millimeters squared in a meter squared. So 5 millimeters squared is 5 times 10 to the minus 6 meters squared. So the pressure you are generating by pinching your forearm is between 7 million and 5 million newtons per meter squared. That's 7,000 kilopascals or 5,000 kilopascals, or between 280 and 320 times your normal car tire pressure. The point being is that that grip there uses the 2 biggest muscles of the forearm, and they are the flexor digitorum profundus and the flexor obliquus longus. And they sit in the deepest flexor compartment of the forearm. And you can see this in the groove on the ulna and the radius. This huge surface area here with the interosseous membrane, one for the flexor digitorum profundus and the other for the flexor pollicis longus. Massive surface area for the pulpi muscles. And these muscles are fantastic. They enable Tom Cruise to hang off a helicopter. They're not the muscles that we want in surgery. Indeed, in my martial arts training, one protects the sword from being drawn by your enemy, by your flexor pollicis longus, holding the suba. And literally, you can pull as hard as you like, but that will stop your sword being drawn. Point being is the pinch and these long flexor muscles do not have any place in surgery. So now I want you to consider that original pencil grip there. And what we've got is pinch yourself with an extended DIP joint, all right? And now pinch yourself. And no matter how hard you try, you can't pinch yourself very hard. The muscles that extend the DIP joint and flex the metacarpal phalangeal joint, and the opponent's muscles there are the intrinsic muscles of the hand, but four in particular on both sides, the lumbricals. That's why we've introduced in the Black Belt Academy freestyle, one salute, 90 degrees, but that brings the palps of your fingers together for the lightest of touches. So consider this. I want you to stroke your face with your knuckles. All right? Yeah, you can't get it very light. But now, touch your face with your fingers. Feel the difference. You should be able to feel almost the grains of salt in sprinkling a little salt on your food. And it's that feel that is important. So I stood opposite Samuel doing a fantastic aortic valve replacement, and he did it very well. And the closure of the aorta was meticulous and was a 4-0 proline, 4 millimeters apart, 4 millimeters deep, all the sutures equal and opposite without no dislocation or slip. Very pleased for him. We started to come off bypass, and the aorta started to do that and unzip. To our surprise, I said I'd better take over, and I went round and asked his sister for a plegited suture to bring the aorta back together again, took the needle to the aorta, and what did I feel? Nothing. I had no tactile feedback of the needle going through that tissue at all. It was a bit like a knife going through butter. I asked for a blade, and I took a little slither of the aorta to send off for histology to confirm my suspicion that this man had severe cystic medial necrosis. Now, the problem is, although Samir, watching him, did a very good operation, everything was technically correct, but the one element I could not assess and did not spot was his ability to hold the instrument. And if you're gripping your instrument, you're not caressing the tissues as described by Lord Berkley Moynihan. And this is an important thing to understand, because the instruments do become an extension of the brain and the fingers. We know that from neurocognitive studies, that you can accurately place the end of your instrument and direct that and feel, providing you're holding the instrument properly. It's never a grip at all. So this is important for you to understand the difference between the extrinsic muscles, giving you the Tom Cruise grip of instruments, and the intrinsic muscles, the lumbricals and the thenar eminence muscles. These two large muscles, the flexor digitorum profundus and longus, exert an enormous amount of pressure. But the intrinsic muscles of the hand are unique that enable us to do fine arts and writing. And this is down to the lumbricals. And their action is paradoxically and extraordinary. They don't have any bony insertion on origin. And they simultaneously extend that and flex those, giving you this precision grip. But they've evolved highly into specialized structures that modulate the tension between the extensors and the flexors. And they are full and rich of spindle cells. And these spindle cells are vital for the proprioceptive movement of the hand. They report position, tension, and movement in real time, making the lumbricals simultaneously the motor and sensory system of the precision grip. But of course, that's the grip. What about the fingers? And this multi-layered sensory organ has unmatched sophistication, not only in its structure, but its ability to detect texture, vibration, temperature, hardness, with the gentlest of forces, whether it is wet or whether it is dry. And that is unique. And this whole science of tribiology is expanding rapidly. And one of the single failures of robotic and laparoscopic surgery, they have not yet been able to feel the tissues. And although the grips and the arms of these robotic tissues are getting more sophisticated and the movements getting more sophisticated, what is missing altogether is the sensory feel of the tissues. You know yourself, this can pick up the gentlest of forces, and it can discriminate between vibratory stimuli differing only in one harmonic phase. We learn more from our fingertips than we do from our eyes. And as an aside, I was thinking of how we learn anatomy, and anatomy being taught in AI. And one of the students who joined the Black Belt Academy, we got into discussion, and I have to agree with him. When do you think babies explore the world by picking it up and feeling? Are we missing a trick learning anatomy in AI when we can't pick it up and feel? Would we learn more if we would be able to feel and rotate and use the organs? So part of this also then, in the Black Belt Academy, we haven't been using gloves, and that is because it's low fidelity and we want to keep it at home. So yes, gloves do reduce your sensory fidelity. And that's why it's important we have the right size gloves. The important thing is that the tension on the fingers should be such that the feel is still there. In microsurgery, there are thinner gloves as well. But we have to accept wearing gloves does reduce the haptic feedback. So let's go through the individual instruments and think about how we actually hold them. First of all, let's think about how we stand. And I'm going to stand back a bit. And if you look at the hand, there are two famous hands on the ceiling of the Sistine Chapel. One is the hand of God, which is slightly flexed. To actually effect a grip, one has to extend the hand. So if I extend my hand back, you can see my fingers starting to flex. And it's in that partial extension that I can get a good flexion. We know that you can't flex the fingers if your hand is palmar flexed. And if the hand is palmar flexed in this position, you have effectively neutralized the function of the forearm muscles and maximized the ability to use the fingers. In martial arts, to get somebody to release the grip, flex the hand. They can't grip if the hand is palmar flexed. They can grip if it is extended. So the slight flexion is a neutral position on the hand. Way of interest, Adam's finger is not fully extended. He's decided not to touch God's hand, apparently, in the picture. But that is the neutral position of the hand. And the neutral position of the hand comes not with the elbows up, because as soon as you bring your elbows up, you engage the long flexors and the forearm muscles, is having the arms slightly extended, not 90 degrees, between 100 and 110, okay, such that you get this palmar flexion. Pianists and typists recognize this as well and support the forearm and typists to remove repetitive strain injury. So you're literally just using the fingers themselves. So how we stand, the height of the table is important in that position. But the other important principle, if we are to feel the instruments and caress the tissues as described by Berkley Moynihan, as the ideal surgical movement is no more than a caress. This is not poetry. This is precise anatomy, understanding the function of the upper limb. And when the table is set at the right height and the elbows are down, the shoulders are by the side, the scapula is in a normal neutral position, you are standing properly, the fatigue is reduced, the long flexors are quiet, and the instruments sit lightly in the palps of the fingers. And the human hand then does exactly what 2 million years of evolution has designed it to do, to feel the way. And the surgeon who understands that it does not require a grip and to grip harder when the going gets tough. When the going gets tough, the best thing is to slow down, relax, and let the hand lead, and do not grab. This is the surgeon's touch. And the question is, if you're about to operate on a patient, are you grabbing them or are you caressing them? And one way to think about it is think always, have you maximized the surface area of the palps of your fingers with the instruments? So let's go through them one by one, our common instruments on the table, and pick them up accordingly. So the forceps are ubiquitously used in both the right hand and the left hand. Immediately, I've got it resting on the first dorsal interosseous space. My index finger is extended, my thumb is extended, and that is the movement required. If I start doing that, note the blanching of my fingers. That is pressure, that's not feel. And I can see the blanching through the gloves of an operating surgeon. Feel it, both hands, both sides, like that. The next important thing is, what about instruments that have got rings? And the common one is the needle driver. Now, the needle driver needs to be held in the palm of the hand and needs to be held along the axis of the pronation and supination, which is between the index finger, the middle finger, and the common flexor origin, and it rotates over and back. We're not flicking of the wrist and stitching. We're literally rotating, and think of it as holding a screwdriver. By the way, did you know the biggest supinator in the forearm is? Any comments? What's the biggest muscle that's doing this? Anybody? Any comments in the chat? I must just have a look. Any comments in the chat from anybody? There you go. No comments yet. Let's see. Anybody answering? No. Well, the muscle that does biggest supinator of the forearm is the biceps. And that's why screws go clockwise, because you're using the biceps. There you go, as an aside. So note, as I'm holding this, I've got 1, 2, 3, 4, 5 pulps of fingers applied to the instrument. I can lift it out, put it in, lift it out, put it in. Literally, if I had a needle on the end of this, and I was teaching the students on Fun Friday practice, if I had a needle, I should be able to feel the difference between the needle going perpendicularly into the tissue rather than picking it. And if I can't feel the difference, I'm gripping the needle too tight. And often you see the knuckles blanching there, and that's gripping it. And I've started to flex my fingers. I don't want to do that. So the question is, how do you actually unlock this? So if we look at this closely, the ratchet is only 1.5 millimeters to 2 millimeters. And that's all the movement is required to undo. So in learning, I'd lift your thumb up. But once you practice, all you need to do is nudge it. And you place the ring over the metacarpal phalangeal joint, such that you can do this abduction with your thenar eminence. Lock, unlock, lock, unlock, lock, unlock. Lock by pressing it down and unlock. But at all stages, I've got 1, 2, 3, 4, 5 pulps of fingers applied to the instruments. Lift it out, put it in. From dissecting tools, my favorite is the Mackintosh scissors. Look how elegant that is. Long shaft and curved blades. The thing is, with all rings, you stroke your face with your knuckles. Do not put your knuckle through the rings. Indeed, if I put my knuckle through the ring, I might not be able to get it off my finger. But if I was to put it down, I'll put it down, and I have to disengage it from my hand to put it down. If I put my hand out, the nurse can put the instrument into my hand. And look in this position. Again, I've not got the DIP joints through the holes. My fingers are applied obliquely, such that the palp of the finger is touching the ring. 1, 2, 3, and my index finger is extended down. The index finger gives me that direction, that proprioception, and the curve of the wrist is for the curve of the blade. It doesn't require force. For those green belt students who graduated recently, and congratulations to you, the exercise of dissecting the skin of a sausage required the lightest of touch without you disturbing the tissue underneath. And that can only be done by holding the instrument correctly. Many of our instruments have got rings, and if you look at all the rings, they're of similar size. And they're all similar size, and I'm sorry, they've all been designed and old-fashioned by predominantly men, and do not recognize the increasing need of our growing workforce of very talented women who have smaller hands. Some companies like B. Braun understand this and running a Can You Feel It campaign and looking at the design of the instruments. But even though the rings are of standard size, the principle of applying the palps of the fingers and maximizing 1, 2, 3, 4, that's just on the side there. You could count that as a half, 4.5, holding the instrument. The same applies to our mosquitoes. Now, left-handers are at disadvantage because I cannot take off an instrument with the left hand. This is the same with scissors, whereas with the right hand, I can take it off. It's difficult with the left hand. So the way you hold the instrument and housed it for the left is literally, again, look at this. I'm holding it 1, 2, 3, 4 palms of fingers. Here, 1, 2, 3, 4 palms of fingers. And I'm taking on, off, on, open, and I can close as well. Okay? Open, close, open, close, open, close. At no stage am I actually gripping these instruments at all. Open, close, open, close. It applies to all the instruments with rings, different size, houstlets, and control. And even with the Leahy. Same again. With the Leahy, again, same setup. 1, 2, 3, 4. Index finger down the instrument, giving me that direction and proprioceptive control. And the ratchets are there just one click. You don't crunch them on because that is far too severe for the tissues or your needs. It's literally one click. And to remind you, it's the 2 centimeters, 2 millimeters, or 1.5 millimeters of locking and unlocking. There's not much movement at all in there. So lastly, it comes down to our knife. Yes, it's interesting watching people eat in restaurants and do they hold the knife correctly. Now, Debrett's is a culture book in England that describes etiquette of all sorts in all walks of life and describes how to hold the knife. And I remember Mr. William Walter Frederick Southwood, my first consultant boss in 1987, telling me, hold the knife like a knife and not like a pen. In that regard, to maintain the sagittal plane of 90 degrees to the tissues, my thumb and the side of my middle finger, the palps, are holding that 90 degrees. My index finger is down the middle. The handle is in the palm. So when I'm making a cut, and if I should not, and you should not see the blade, if it's rotated there, that's going to bacon slice. That's going to bacon slice. That's going to bacon slice. So from above, you should not see any blade at all. And as I take it down, I'm supporting the blade. And if I'm following this crease, I should follow the crease all the way down. But the angle that I apply the blade to the tissue is there, that angle, because the cutting part of the blade is this part of the scalpel, not the point, but this bit here. So holding the blade again, note that I have 1, 2, 3 fingers now applied to the blade and it's sitting down. Now I don't need to press hard. It's literally the weight of my forearm. And as we'll go through our blade lessons later on, it's important if you're holding the blade softly, you can feel the spaces between even compressed sandwich meat. And it's that feel that you can only appreciate if you're holding the blade as the lightest of touches. Now, what do you say if it's a small blade and you're doing small work? Indeed, then you may change the blade to more a pencil grip. But that pencil grip usually means that you're dissecting around curves. And this flat blade then becomes difficult to maintain the blade perpendicular on the curve. And this is where we go back to a pencil grip There you go. Literally the same as a pencil. And with the pencil grip in this barren blade, I can control, as I come round in a circle, a 90-degree cut. And there has this movement. So as we're looking at this pencil, the last rotation that we have and describe with finger-held movement is rotation of the pencil. So I'll put the blade down for safety reasons to demonstrate this rotation between my fingers. And it's that rotation that is required. In fine surgery, with a 7/0 or 8/0 or even 10/0 needle, there's very little movement that's required for pronation, supination. The movement is not, again, flick of the wrist. It's not flexion or extension of the fingers. It is the finest of rotations between your fingers. So this comes back down to what the function of the upper limb is all about. To get rotation of the fingers while we're here, your upper limb, your wrist and elbow, put your fingers in the position for you to do the rotation. I'm not rotating fine movement with my wrist whatsoever. I put and align my instruments, and now I can do movement. I'm not using my arm to do fine movement. I'm using my arm, forearm, elbow, shoulder, and wrist to put finger-held instruments in the right position and effect the lightness of touch and rotation that I require. In a like manner, think of the most useful tool that you have as a surgeon, and the best form of dissection, if uncertain as well, is use a finger to feel. It reminds me of an exam question I had in primary FRCS back in 1987, where the examiner was asking me how I deal with a gastric bleed. So we'd gone through it all, and now we're at operation, and he said, and now what you do? How would you identify it? And what he wanted me to do in the end, old-fashioned surgeon, was open up the stomach, look for the bleed. But he said, feel for the protruding vessel. Actually take your glove off and feel for the protruding vessel, because the bleed at the bottom of the ulcer, you will feel the lightness of touch. He wanted me to do that as the answer for the primary FRCS exam. But the point is that your hand, I hope you now understand, does far more than you can imagine. Unless you appreciate the physiology and the anatomy of the hand and understand it's your body position, how you stand, how you neutralize the small muscles of the hand that are important to achieve that lightness of touch. That when your arm is abducted, you're going to get tired. But we do need to abduct our hands on occasion, but in that position, perhaps we'd step in to our abducted elbow to reduce that. Be conscious of the grip. And if you notice the blanching of your fingers, just for a moment, press your fingers on the tabletop in front of you. If you notice your nails blanch, that's pressure, that's not feel. These are important elements that will enable you to feel and understand the tissues, whether it is gross anatomy or whether it is even the finest of tissues as well. Your ability to discriminate all depends on how you use your hand. The shoulder girdle, as we got here, all it is doing in combination is putting that hand in a position to enable you to do a job. In some cases, I have my hand in the air and I have to do this. That's still using the screwdriver rotation. My elbow's in the air, but I can get that rotation at every level. And all the shoulder girdle is there to do is to put this, your most precious instrument, in the right position for you to use it correctly. And with that, I'd like to actually ask my fellow senseis to join in the conversation. And Mr. Caddy is indeed a hand surgeon, so he will enlighten us further. And thanks to him, I have this barren blade. And Prof. Seeley has, in her wisdom in obs and gynae, understands the need to feel the instrument. So, Prof. Seeley, Sensei Caddy, do join us. Thank you, Prof. Seeley.
Thank you very much, Prof. Yeah. This is a very good description to understand it. Your basic anatomy and then the physiology of the tissues that what we are operating. Yeah. And that remind me to differentiate the artery and vein and then also the ureter. We supposed to tie artery and then veins, but it's not the ureter. So of course, in the silent mental, we can demonstrate our students how the positions or the peristalsis of the ureter. But we can show them the structures and we can let them feel, just you mentioned about that, the elasticity of the artery and then the easy collapsibility of the vein and then a bit slippery, a kind of the feeling of the ureter. But of course, in a theater, this is not only a touch, also the eye, you have how you have to see this, just this kind of the structures, the position, not pulsating or peristalsis. Yeah. So,
Indeed.
yeah, thank you very much, Prof. Yeah. All right. So it's like we always mention about the sixth sense. We have to use all our sixth sense during the surgeries, not only, it's just one information that gives you to differentiate. Yeah.
Indeed. And you cannot separate it, but the fact that you will learn a lot more by lightening the feel of the instruments, and you get a lot more feedback from the tissues if you do that. Mr. Caddy, your observations, please.
Well, once again, thank you. Another masterclass. So as part of my training, I ended up being a hand surgeon. So I've got I'm very aware of the hand and upper limb, how it works, what can go wrong with it, and how to either prevent or repair problems that arise in the upper limb. So all of this brings it together in a way that one doesn't normally think about it. So thank you for that. But the upper limb is unique in allowing us to do things, but we can now use our mind to think about how could we do it better. And combine that with AI and robotics, we can then plan for operations which have not even been thought of as yet.
Coming on to the robotics thing, Chris, I felt some of these, and when I've used them, I feel more the mechanisms of the whole thing rather than the tissues. And I note they're getting more sophisticated, and I've just saw a LinkedIn advert, and they did have, pleasingly, this fine control and grip on the console. But again, it's the position of your arm at the console and the way your wrist is placed that will enable you to do this. But you still don't get that tactile feedback from the tissues.
Oh, I completely agree. So some people have been looking at AI robotics in a different way, how you interface the human mind and hand with the whole process. So it doesn't have to be sat at a module. There are other ways of delivering it, and they're being tried out.
And from your experience and operating, have you got stories about how you held instruments or?
No, but once again, it comes back to this lightness of touch. If you try and strangulate the instruments, you get the feedback, it's exhausting, and you'll end up with pain and feedback from your body saying you're not doing this right. So you have to, first of all, set yourself up for success. But if things are not going the way you want them to go, you need to think, why not? What am I doing wrong? And you need to go back to first principles. So what you're trying to do here is to train the next generation not to get themselves into a situation where they cause harm to their body, and get them to do it. It's not a question of waiting until something goes wrong. It's about foreseeing what might go wrong and trying to prevent that in their daily lives.
So I had some debriefing questions that you could perhaps use as a trainee surgeon as you leave the table. So the first question to ask yourself, did the table stay the same height throughout the operation? Did we compensate with our shoulders with poor posture? And did you ever remember the table tilts from side to side? Question number one. Question two is that when you're using your instruments, were you driving your instruments with your elbow or with your wrist or with your shoulder? And did you notice that you were doing it or feel the difference? Next question you ask yourself, at any point, do you think, did you actually feel the tissue? Or were you moving through it? Now, this is, be honest with yourself, even with your practice in dissections in the low fidelity organic models. Ask yourself, did you feel the tissue? And if you're not feeling the tissue, just pause for a moment, please. And in future think, I'm not feeling the tissue. Try lightening your hold of the instrument. You're not going to lose control, but you're going to get a lot more back from the tissue. So that's question 3 in your debrief from your operation. Contrary to that, almost the opposite, was there a moment during your operation when your grip tightened? What triggered it? And what did it cost? What was the consequence? Take a note of that and write it down and reflect. And lastly, always after practicing with the instruments or in an operation, did the instrument feel like an extension of your fingers, or was it just a tool in your hand? And if you answer the latter, again think to yourself, what can I do to actually get it to become an extension of your fingers? So the extension of the fingers, I put it to you, comes with lightening your touch by maximizing the surface area of the pulps of your fingers, standing properly and isolating the muscles of the intrinsic muscles of the hand and letting that do the work for you. There's no need for brute force. I was chatting with Prof. Lena, who came to the black belt reading. She's an orthopedic surgeon, and we've always stereotyped orthopedic surgeons as rugby club boys with knuckles dragging on the ground and brute force. And we see some of these grotesque videos of them hammering joints and banging things in as well. No. As in martial arts, it's technique before power and speed. And if you're having to do that and putting lots of force into it, even as an orthopedic surgeon, I'll challenge you to say, do you have your technique right? What's interesting, actually, and I'll share with you, one of the reviews came back on our banana scoring paper, and the surgeon said, does it really matter? This reviewer said, does it really matter if the technique is not perfect? I've contemplated his answer for some time, and I've replied to the editor and challenged his thinking. If we're saying that flick of the wrist is okay, and he was actually suggesting this might take longer, and therefore it's going to be deleterious. Well, it might take longer. And I also challenged him, are you going to accept anything less than a perfect and respect of the tissue? Because that's what he's implying. Well, that's where you practice. You practice till you can't get it wrong. And I'm not asking you to practice on patients doing this. In the Black Belt Academy, we've deconstructed all of this and set some fiendishly difficult organic models that have put your skills to the test. So I've been bold. I've replied to the editor, and I've challenged the reviewer of the paper and asked them to try the exercise themselves, to send me a photograph and then comment before telling me that it is acceptable not to be perfect and to be a little bit rough of the tissue. That's not acceptable at all. Any questions?
It's not acceptable in your mind.
No, it's not acceptable. Nobody should accept it.
It's going to be interesting to see how the editor takes that information and feeds it forward to his reviewers to say, have you tried this?
Yes.
Because one of the problems about this, a lot of it is action learning.
Yes.
Although you're deconstructing the whole thing, at the end of the day, you've actually got to do this and experience it in time and place.
Yes.
So it's about the feel of the instrument. It's about the flow of the whole operation.
Yes.
And that's not something you can teach in a classroom. You actually have to do it. And the reviewer needs to understand that when he is giving you critique or feedback, it's to put it into the context in which you're trying to apply this.
Indeed.
And it's not in a book, it's actually doing it in your daily life, your working life.
I'm looking forward I'll send you the letter. It was carefully crafted and challenging.
Good.
Carefully crafted.
You've come very far then.
But I think about my learning of Iaido. Okay. You see, mastery is a journey, it's not a destination. And I don't expect you're going to get it perfect. But that doesn't mean to say that we accept less than perfect. We've got to learn and practice until we get it perfect. If you look at the circle behind, it's a brush circle. It's an imperfect circle, but it's complete. But we continue going around that cycle until we get it as complete as we can get it. But to imply that not quite perfect is acceptable is ridiculous. So the sensei from the end of the room can spot my sword, and the angle wasn't quite 45 degrees down. And he spotted that. He said, no, that is it. Frustrating, yes, but it gets me going back for more, and I've got to get it right every time. Why do we drive that in our thinking and surgery? Because we do know you respect the tissues will look after you. That the lightness of touch and the caress that Berkley Moynihan describes means that the tissues will heal, close properly, less scarring, less thrombosis, less pain, early mobilization, and return of function with reduced wound infection. But you're not going to see it tomorrow. You get this right now, you will see it throughout your career. And if you continue to learn and ask these questions of yourself as you're operating, you're learning by doing and reflecting on your actions. And I hope that we are giving you a foundation to do that. So we're going to continue our journey next week, and we'll start our cycle. It's like Wagner's cycle again, the ring, and we're talking about now we understand how to hold the instrument. We're going to put our needle in our needle driver and begin to understand how to use that. thank you very much for joining the Black Belt Academy this evening. Thank you to my fellow senseis, Professor and Piscadi, for your work, and any last comments from either them or the audience.
The first one is that you mentioned about the adjusting the table height, Prof.
Yes.
Yeah, because it's depend on the situations when arises at the time of the surgery. So it's like always, this is a good point to check whether the operation theater, the table is functioning well or not. It's like adjustable, non-adjustable.
Yes.
Yeah, so it's difference between the anatomy dissection and our silent mentor.
Yes.
In our silent mentor, all the tables are, adjustable. It's exactly like I think you will notice that. Yeah.
Yes.
But the anatomy dissection tables, they are the fixed tables, put on the formalin silks bodies are on the fixed table. But whereas the silent mentors, it is exactly like how in the operation theater. So when we were opening up the abdomen in a different height of the table, but when we are going in deeper into the tissues, probably you might want to use the stool and jump, and so that at least
or drop the table down so you can peer further over the top.
Yes, Prof. Yeah, sometimes we drop the table down, and then we still need the stools because
operating is a lot more dynamic than people think.
Yes, definitely.
And it's like learning to drive a car, isn't it? And learning to appreciate the acceleration of the clutch and the feel for it.
Yes,
you
definitely.
need to understand the table gives you a lot of functions, and even that 1 or 2 degrees or 1 or 2 centimeters of that slight tilt will make a significant difference, not only to what you're looking at, but how you're standing and your ability to position your hand to make the right stitch. And this
sometimes we might ask the head down a little bit, so that the bowels will move away to the upper part of the abdomen, so it's as a clear from the pelvis. Yeah, so that's the thing. This is number 1 point. The second point is that holding the instrument in the right way. For example, when we do dilate, or measure the uterus cavity, this is what my teacher taught me. Never use the instrument like how you hold the knife set. All right. So it's like only with the very light force with the fingers.
And you've got your 3 fingers applied to the instrument there.
Yes, it's but not the whole height with the whole hand. Yeah. So when you put it into the uterus, blindly into the uterus, whether you can see it or not. So it's like it was slowly introduced. Once we touch the uterine fundus, we could get this kind of a sense of touch. So actually, you are 100% correct. Our instrument, it is the extension of our hand, because we cannot reach with our fingers to the uterine fundus, but the instrument, it is a correct instrument, and then with the correct force and with the holding the instrument, correct way of the holding the instrument, then you can gently. But if you don't use or don't hold correctly, and then with the very strong force, you might perforate the uterus. So this is very, very important, of how gentle you have to feel it or hold it, the instrument in the right way. That, again, what Prof. Chris just now mentioned, we can't just teach, but we should be hands-on, hold their hand even in the operation theater in order to prevent all the complications. Yeah.
And
thank you very much.
That again, Prof. Sile, is a wonderful example in obstetrics and gynecology. It's how you probe, and that was a beautiful description of how you probe as well. And a lot of our work is in endoscopic, so it's understanding that field too. So thank you very much indeed. we look forward to seeing you next week and look forward to further participation. And I'm going to stop recording there.